Sure.
Okay, great. Okay. So I'm going to read the introduction. So welcome, everyone. We are at the session 345 session on management of acute oral infections in the medical setting. I'm hoping that you can hear me okay. If you can't, go ahead and put it in the Q&A chat. All right. So we have the pleasure. Pardon me? We're good? Okay, so we have the pleasure of Dr. Khouja on with us for this session. She is a dentist, a health services researcher, and a second-year postdoc fellow in the Division of General Internal Medicine at the University of Pittsburgh School of Medicine. Dr. Khouja received her degree in dentistry from King Abdul Aziz University in Saudi Arabia. She completed a master's in public health with a certificate in health systems leadership and management from the University of Pittsburgh Graduate School of Public Health. She then received her PhD in health services research and policy also from Pitt. Dr. Khouja's research focuses on areas of high importance in dental public health, including prescribing in dentistry and access to oral health services using a secondary data set and advanced statistical methods. Her current research uses mixed methods to develop a provider-centered intervention to improve opioid and antibiotic prescribing in emergency department settings. Dr. Khouja's work on opioid prescribing in dentistry has informed the upcoming American Dental Association guidelines on acute dental pain management in dentistry and has collaborated on policy reports locally and internationally. As part of her postdoc training, Dr. Khouja works with NIH-funded researchers and multidisciplinary teams, including clinicians, health policy experts, health service researchers, and biostatisticians. Her research expands beyond dentistry, exploring opioid prescribing in health systems and antimicrobial consumption globally. Dr. Khouja is one of few dentists nationally that have an interdisciplinary background in oral health epidemiology and policy and trained in oral health services research. Dr. Khouja's research has been supported by federal and non-federal funding, including the inaugural Challenges in Managing and Preventing Pain Seed Award. Dr. Khouja, I thank you very much for sharing your expertise today for the session titled Management of Acute Oral Infections in Medical Settings.
Thank you so much for your kind introduction, and I'm really privileged to be here today talking to experts on this important topic. And hello from Pittsburgh. I know like everyone is in, I guess, Illinois, and it's really amazing that you guys include oral health in your antimicrobial stewardship efforts. So before we begin, just want to say that I have no conflicts of interest to disclose, and I just have one slide that has unpublished data yet. So it will have this like icon in front of it, and I'd be really appreciate it if people don't share that information because it's unpublished yet. And although like my talk is kind of geared toward medical providers, but it also has a lot of description of the American Dental Association guidelines for acute pulpal and periapical conditions. So it's very relevant to dentists. And the hope is that, this will kind of help us all have those conversations between dentists and providers on how we take care of these patients. So I will go through a lot of some basic information about tooth anatomy and tooth decay or dental caries. And then what are the acute oral infections that we're talking about in this presentation. Then the bulk of the presentation will be on the American Dental Association guidelines for acute pulpal and periapical conditions. I'll go over one study on the concordance of antibiotic prescribing among dentists with the current guidelines, and then I'll end with how can non-dental providers or medical providers help their patients who present to them with these conditions. So the objectives, I'll let you read them in your own leisure. So very quick dental anatomy stuff. So this is a cross section of a molar in the lower jaw or in the mandible. And I think it's important to describe some of this terminology because the conditions uses a lot of dental specific terminology that would be helpful to explain. So the outer part of the tooth, or you're visible in your mouth and that you can feel, is the crown, and then embedded in the bone is the roots of the tooth. The roots of the tooth adhere to the alveolar bone or the jaw bone through the periodontal ligament, which is this like pink line around the roots of the teeth, and they includes fibers, nerves, and blood vessels. So the tooth itself is the outer part of the crown is made of the enamel, which is the hard substance. Doesn't have much innervation. Then the second layer is the dentin, which is makes up most of the tooth. That's more sensitive and less hard than the enamel. And then the dentin covers the pulp cavity, which includes the nerves and the blood vessels that enter the tooth through this area that you can see here. That's called the apical foramen. And when we're going to talk about the guidelines, we're going to talk about like pulpitis. So this is where the pulp is, and again, inflammation of the pulp. And important to remember, the closer you get to the pulp, the more painful things are. The other thing is that this is called the apical region of the root, and so we're going to talk about periapical periodontitis and apical abscess. So that pertains to inflammation of the area around the apex of the root. So again, this is for dental providers. This is like basic, but I think for people who are not familiar with dental caries, it's a good very quick overview of what tooth decay is, or dental caries. So dental caries is the most common chronic disease of childhood. It's multifactorial, but at the tooth level, what happens is when the pH in the oral cavity drops, mainly due to sugars in our food, that creates an environment that's favorable to acidogenic and acidophilic bacteria. And when that acid attack happens, that causes loss of minerals or demineralization of the tooth structure or the enamel. In normal conditions, the pH of our oral cavity goes back to normal, and then there's a remineralization process, so the minerals go back into the tooth, and then there's a balance between the demineralization and remineralization process. However, when conditions are more favorable to demineralization, or the continuous acid attacks, that's when we start losing tooth structure, and then cavities basically happen. And although there are a lot of bacteria that are involved in dental caries, the most prominent ones are Streptococcus mutans, which you can see here. There's pink, the things around the dental biofilm, which is the blue one, and then Lactobacilli species. So the oral infections that we're talking about today are really a consequence of progression of dental caries. And in this picture, I'm just describing how the progression happens and then the consequences. So at the beginning, when the caries are just in enamel, that's usually sits far away from the pulp. Usually patient doesn't feel pain. Sometimes they feel pain when with sweets, but then it immediately goes away. Then when and this is a picture, I think, of caries in enamel. So clinically, you just see these things. It's very superficial, not so painful. When caries progress into dentin, that's when you start feeling more pain. A patient starts feeling pain, especially triggered by usually thermal stimulation. However, the pain kind of goes away immediately. At this point, the closer you get to the pulp, the pulp becomes inflamed. However, when it's far away like this, it's reversible, meaning that this vital pulp can heal itself when we stop the progression of the disease, which is usually through dental fillings. When the inflammation continues, however, we don't stop the progression of disease and it gets into the pulp, that's when the pulp is inflamed irreversibly. meaning the pulp cannot, it's still vital, but it can't heal itself. So even if we put just the filling there, it won't help things. What we really need to do is remove the causative agent, which is the inflamed pulp, to prevent, kind of get rid of the inflammation and stop the progression of the disease. And this is like just a clinical picture of a more deeper carious lesion. And with this level, the patient usually has spontaneous pain. They have an exaggerated response to thermal stimulation, especially cold, and they will kind of complain of lingering pain after that cold stimulus is removed. If we don't, if that pulp, the inflamed pulp, eventually, if it's not like, if we don't remove it, it dies, it becomes necrotic, and that infected pulp, then that dead pulp can become infected, and the infection can spread into the periapical region here. And when it's just inflammation, it can cause inflammation of this area around the root. And at this point, the patient doesn't have any sensation to thermal changes, but they can have pain when they're biting or when on palpation and percussion. So when you tap the tooth, there's some pain. And again, that can progress also into an abscess, so it goes into the alveolar bone surrounding the tooth, the root apex, and causes an abscess that can be painful. You see that swelling intraorally, and that's usually filled with gram-negative anaerobes. And in an X-ray, you would see like there's radiolucency around the root. So these are the irreversible pulpitis, which is the vital pulp that is incapable of healing itself, and then the necrotic pulp with apical periodontitis or an abscess, or the dead tooth with the abscess, are the two conditions that the guidelines mainly focus on, and that we'll be talking about today. So the prevalence of these conditions is not really known in dental clinics. Some research shows that 9% of patients who come to the dentist have complained of dentoalveolar pain or dental pain in the past 12 months. Interestingly, though, these conditions are the most common cause for patients to come to the ED with dental pain. So for many reasons, with the biggest one of them being access to dental care. So it's a common reason for patients. They should show up in the ED, and it's actually more common than when patients come to the ED for myocardial infarction. So it's 10 times more common than myocardial infarction. And because of lack of resources in the ED and limited training of ED providers, they can only provide palliative care for these patients, usually in the form of antibiotic and opioid prescribing. So previous research has shown that patients who come to the ED with dental pain, or what we call non-traumatic dental conditions, 50% of them get an antibiotic, 40% fill an opioid, and then 30% fill both medications, although not always recommended. And this is like from my own data. We did an analysis looking at a national data set of commercially insured individuals from the Optum EHR integrated claims data. So we looked at ED visits from 2011 to 2019. Those are the blue bars, ED visits for non-traumatic dental conditions or dental pain. And we also looked at the percentage of these visits that ended up with an antibiotic or an opioid prescription. And interestingly, so it confirms what is in the literature, that patients get an opioid and antibiotic for dental pain regardless of recommendations. And then we see a drop in opioid prescribing, which is in green. However, we see that the percentage of visits getting an antibiotic, so ED visits for dental pain that get an antibiotic, has doubled over the study period. And in 2019, 1 in 5 patients who came to the ED with dental pain got an antibiotic, regardless of whether it was needed or not. And I think and some of our qualitative work, so talking to ED providers, kind of confirms that. So ED providers now have like some kind of criteria or thought process of when to prescribe an opioid for a patient with dental pain. However, all of them prescribe antibiotics for dental pain, regardless of whether that's recommended or not. And I think that's an important thing for dental providers to know too, in their communications with both patients and other providers. And again, I think this has been like repeated throughout these talks, but and I know this is this audience does not need any convincing about this, but why is it important? Why should we be careful about prescribing antibiotics for acute oral infections? Well, as mentioned in the previous talks, at an individual level, even these short courses of antibiotics, such as those for dental pain or dental infections, even when prescribed appropriately, they can increase the risk of adverse effects in patients, including allergic reactions. And we saw from Dr. Durkin's slides, there's an increased risk also of C. difficile infection, especially with prescriptions of clindamycin. And then antibiotic prescribing overall contributes to the greater global threat of antimicrobial resistance. So now I'm going to go into the guidelines, and this Dr. Kennedy in the earlier talk had kind of given an overview of these guidelines. I'm going to talk about them in more detail. And as she mentioned, this was like an interprofessional team of experts, including the people we heard from today. So Dr. Abt, Dr. Durkin, Dr. Kennedy, and my mentor, Dr. Kitty Suda, who's an antibiotic stewardship expert, were all in these guidelines. So these guidelines were developed by the American Dental Association, and they were published in the Journal of American Dental Association in the fall of 2019. And the title of the guidelines is Evidence-Based Clinical Practice Guidelines on Antibiotic Use for Urgent Management of Pulpal and Periapical Related Pain and Intraoral Swelling. And so the way I'm going to go through the guidelines is first describe the objective of the guidelines. I'm going to talk about the target population. Then we're going to go into the guidelines themselves and when antibiotics are recommended. And then we'll go over when antibiotics are recommended, what antibiotic regimen should be prescribed. So the objective of the guidelines was really to help patients and clinicians make that determination of when it is appropriate to use oral systemic antibiotics for the urgent conditions that I'm going to mention in a minute. It's important to note that these guidelines were meant for immunocompetent adults. So it's not for children, and it's for immunocompetent patients, meaning they are able to fight bacterial infections. And it's also for acute conditions, so it doesn't include chronic conditions. The two conditions that we talk about are symptomatic irreversible pulpitis with or without symptomatic apical periodontitis. So if you look at kind of like the first picture, so that's a vital pulp that is inflamed and cannot be healed. And whether that inflammation has gone around the tooth, the root. So this is like the most kind, I think, from my perspective, the most severe pain the patient can experience is that kind of spontaneous pain that wakes you up at night and lingers with a thermal stimulation. The other condition is pulp necrosis and localized acute apical abscess. So that's a necrotic pulp or a dead tooth. And that has that intraoral abscess or that swelling that is spreading in the alveolar bone. And these recommendations really depend on whether patient has access to immediate, definitive, conservative dental treatment that I'm going to talk about in a second. So the target population for these guidelines, they were intended primarily for general dentists. However, the guidelines can be used by specialty dentists, dental educators, policymakers, and most importantly, they can be used by non-dental healthcare providers such as emergency and primary care physicians, infectious disease specialists, advanced practice providers, and pharmacists. And Dr. Kennedy mentioned earlier that they are making these guidelines more friendly for non-dental providers. So we're looking forward to that. So what is definitive conservative dental treatment? So definitive conservative dental treatment in medicine, I think they call it source control. Basically, it means removing the causative agent that is causing the infection, which will, solve the whole problem. So it's that's really what treats the problem. And in the cases that we're talking about, it's really the removal of the infected pulp or inflamed pulp. So pulpectomy, which is the kind of the first stage of root canal treatment. Or it's like when you have that abscess, doing incision and drainage. So again, definitive conservative treatment is the only real treatment that solves the whole problem. The antibiotics and pain medication that we provide are only palliative. So again, I want to emphasize this. Definitive conservative dental treatment is source control, and I'm going to start referring to it as a dental treatment. And when they say immediate, that means that the patient can get this treatment within 1 or 2 days from when they are seen. So overall, the guidelines recommend against antibiotics in most clinical scenario, irrespective of availability of dental treatment. And antibiotics are only recommended in cases with systemic involvement or when the risk of progressing to systemic involvement is high. And by systemic involvement, we mean the patient has fevers, chills, malaise, facial space involvement, or lymph node involvement. And here I have included some pictures of cases where they've become more severe with facial space involvement. So we have Ludwig's angina here, and here are the cases spreading in the maxilla. So those are like real emergencies, and they record, signs of systemic involvement. So now I'm going to go into the guidelines themselves. So the first part talks about when dental treatment is not immediately available. So meaning the patient cannot be seen by a dentist or get the dental treatment within a couple of days. So for our first condition, which is irreversible pulpitis with or without symptomatic apical periodontitis, again, that's a vital pulp that is inflamed and incapable of healing. And they can have that pain around the root also. So usually patient has like this spontaneous severe pain, exaggerated response to thermal stimulation, and then they might also have pain and biting, but there's no like visible signs of an abscess. So in these cases, the guidelines recommend that antibiotics, we don't prescribe antibiotics basically. So no antibiotics in cases of irreversible pulpitis. And from a pathophysiological perspective, this is mainly because all that pain and is really caused by inflammation and not true infection. And so the guidelines recommend referring the patient to dental care and to provide interim monitoring. And providing interim monitoring means that to instruct the patient to call the provider if the condition deteriorates or if they can't get into dental care within a couple of days. The second condition is pulp necrosis and symptomatic apical periodontitis. So this is the case where there's a dead tooth or dead pulp. So no response to thermal stimulation. And then the patient has pain on biting or on palpation or percussion. So like when you tap the tooth, there's pain, but there's no abscess developed yet. So in these cases, antibiotics are also not recommended, and patients should be referred to dental care and provided interim monitoring. However, the guidelines do recommend delayed prescribing if the patient can't get into dental care within a couple of days. So I think Dr. Durkin talked about delayed prescribing, but basically what the guidelines recommend is to give a patient a post-dated prescription of antibiotics and tell them to fill that prescription within 24 hours to 48 hours if the symptoms start to get worse or if they start seeing pus formation and intraoral swelling. The last scenario is pulp necrosis and localized acute apical abscess with or without systemic involvement. So this is again a dead tooth, so a necrotic pulp that does not respond to thermal stimulation. However, that's when you start seeing that abscess intraorally. And in this case, the guidelines recommend antibiotics, regardless of if the patient has or does not have systemic signs of infection. And even when the patient doesn't have signs of systemic infection, but they can't get into dental care within a couple of days. That's why the guidelines recommend antibiotics, because they can progress to that case of systemic involvement. So this is the only case where antibiotics are recommended. The guidelines also recommend urgent referral to dental treatment, and that the patient should be reevaluated within 3 days, either like by an in-person visit or like calling them to check on their the signs of the systemic infection. Guidelines also recommend that if there are concerns of deeper space infection or like a life threat to the patient, that they be referred for urgent evaluation in an urgent care clinic or at the ED. So that was the first set of guidelines when dental treatment is not immediately available, so within a couple of days. The second set is when dental treatment is immediately available. And at this point, remember we said source control. So here the dental treatment is really what is needed. And we're thinking about antibiotics here as an adjunct to dental treatment. So for cases in irreversible pulpitis, so that a vital pulp that is incapable of healing, that severe spontaneous pain, once you remove that pulp, so you do pulpectomy or you start root canal treatment, that's it. You don't need to add in antibiotics as an adjunct. In cases with pulp necrosis and symptomatic apical periodontitis, so that's the dead tooth, and then there's pain and biting, but there's no intraoral swelling or there's no abscess. Again, once you start dental treatment, no antibiotics are required as an adjunct. The last case here, the guidelines kind of separate when there is and is not systemic involvement. So in cases of pulp necrosis or a dead tooth, and there's that localized apical abscess or the intraoral abscess, the swelling, but there are no signs of systemic involvement, and you can start dental treatment, then adjunctive antibiotics are not recommended. The only case where adjunctive antibiotics are recommended are when in cases where there's pulp necrosis, so a dead tooth, and localized apical abscess, the intraoral swelling, but there are systemic signs of involvement. So you initiate the treatment, you do the dental treatment, and you also prescribe antibiotics. And in these cases, again, if there are concerns of deeper space infection or immediate threat to life, then the patient should be referred for urgent evaluation in urgent care in the emergency department. So that was like the end of when antibiotics are recommended. So to recap, it depends on whether a patient has immediate access to dental care, so they can get the dental treatment within a couple of days. In cases when a patient can get treatment, the antibiotics are only recommended as an adjunct in cases of a pulp necrosis or a dead tooth with an abscess and systemic involvement. In cases when a patient cannot get to dental care within a couple of days, then antibiotics are recommended in cases of pulp necrosis or a dead tooth with an abscess, with or without systemic involvement. So when antibiotics are recommended, what should we prescribe? So it depends on whether a patient is allergic to penicillin or not. If a patient is not allergic to penicillin, then the first line treatment is oral amoxicillin, 500 milligrams 3 times a day for a duration of 3 to 7 days. Or oral penicillin with potassium for 500 milligrams 4 times a day for a duration of 3 to 7 days. And if first-line treatment does not work, then the guidelines recommend broadening antibiotic therapy to include metronidazole for 500 milligrams 3 times a day for a duration of 3 to 7 days. Or you can just stop the first-line treatment and switch the patient to amoxicillin and clavulanate for 3 times a day for 7 days. Now, if a patient is allergic to penicillin, as we have heard from earlier talks, sometimes the patient doesn't really have a real penicillin allergy. And so it will be, and I think Dr. Kennedy provided some resources of like figuring out when a patient is really allergic to penicillin. But within the guidelines, they say, ask the patient if they have a history of anaphylaxis and angioedema or hives with penicillin, ampicillin, or amoxicillin. So if they do not have those, then prescribe cephalexin, 500 milligrams 4 times a day for a duration of 3 to 7 days. If a patient is truly allergic to penicillin, then the guidelines recommend azithromycin with a loading dose of 500 milligrams on the first day, followed by 250 milligrams for an additional 4 days. Or the second choice is clindamycin, 300 milligrams 4 times a day for 3 to 7 days. And again, if the first-line treatment fails, then broaden the antibiotic therapy to include metronidazole. So some comments on antibiotic prescribing. And I think this also came up in Dr. Durkin's talk. So the guidelines recommend a duration of 3 to 7 days. And really, they talk about how antibiotic courses of 3 to 5 days for acute oral infections are likely as effective as 7-day courses. And this supporting evidence comes from medical literature that found that using the shortest effective treatment to maximize benefit while minimizing risk of antibiotic adverse effects is actually supported by evidence. So I included here a table that comes from a website called Shorter is Better, by Dr. Brad Spielberg, who is an infectious disease expert, and he continuously studies the effectiveness of antibiotic duration. And what they have found is that for a lot of infections, a shorter duration of antibiotic treatment is actually equal to longer duration. So for example, for community-acquired pneumonia, antibiotic duration of 3 to 5 days is actually equal to 5 to 14 days. And so we can think similarly with oral infections. And if you're like me, I was trained to tell the patient to finish their course of antibiotics because that kind of decreases the risk of antimicrobial resistance. However, it turns out that's not true. And the guidelines recommend that you tell the patient to discontinue antibiotic treatment 24 hours after their systemic signs of infection start to resolve, irrespective of reevaluation at 3 days. Again, if you recall the guidelines, the first-line treatment by the guidelines is amoxicillin and penicillin. And so from my personal communications or talks with local providers here, medical providers, they seem to prefer penicillin for oral infections. However, the guidelines say that amoxicillin is preferred, basically because they're more effective against various gram-negative anaerobes and have a lower incidence of gastrointestinal side effects. And again, when patients are truly allergic to penicillin, azithromycin was the first recommendation. However, keep in mind that azithromycin has a higher rate of bacterial resistance than other antibiotics. And so the patient should be instructed to closely monitor their symptoms and contact their provider if their infection starts to get worse while they're on azithromycin therapy. And with clindamycin, clindamycin has that black box warning from the FDA of increased risk of C. difficile infection, even after a single dose. And so the patient should be instructed to call their primary care provider if they start developing signs of C. difficile infection, such as fever, abdominal cramping, or 3 or more loose bowel movements per day. And then another comment is that when cephalexin is the first-line treatment and then the patient doesn't show signs of improvement with that antibiotic, a provider should have low threshold to add in metronidazole therapy to broaden the antibiotic therapy. So those are the guidelines. And then they ended up with, or I'm going to end up with a question about, do antibiotics really work for dental pain alone? So it's kind of, I guess, common that providers give patients who are in severe pain antibiotics in hope to help them with that pain. However, we know from strong evidence that dental pain is actually caused by inflammation. And so in the systematic review that accompanied these guidelines, they did evaluate dental pain as an outcome for antibiotic therapy in these cases. And it's important to note that all the studies that they've included for like antibiotic therapy versus non-antibiotic therapy for these pulpal and periapical conditions, everyone was prescribed analgesia. So they looked at it as do antibiotics provide an additional benefit for pain relief in these patients? So within the available evidence that we have for outcomes of experiencing pain or pain intensity within 24 hours, 48 hours, and 7 days, there were no clinical or statistical significant differences in patients who did and did not receive antibiotics in experiencing these outcomes. Also, if we think about it as, so if a patient takes antibiotics for these conditions, are they less likely to use analgesia? And again, within the evidence that we have, in this, the first graph that I'm showing is for cases of irreversible pulpitis, so that vital inflamed pulp that can't heal itself, the severe pain, and patients don't have immediate access to dental care. When patients do receive antibiotics, they are kind of slightly less likely to get more ibuprofen. I think it was like they're likely to take half of a 600 milligram dose of ibuprofen compared to patients who do not take antibiotics. And if you see here from the forest plot, it was statistically non-significant. And the second set here looks at if they need rescue analgesia in terms of acetaminophen and codeine tablets. And again, whether a patient takes an antibiotic or does not take an antibiotic, it actually doesn't make a clinical or statistical difference. Actually, patients who took an antibiotic here are more likely to get rescue analgesia, but it wasn't clinically or statistically significant. And for patients who take antibiotics as an adjunct to dental treatment, we only have cases with pulp necrosis and apical periodontitis or an abscess. And in those cases, patients who do take an antibiotic are actually more likely to get ibuprofen, but again, it was not clinically or statistically significant. And then there was no differences in getting rescue analgesia, whether you take an antibiotic or not, as an adjunct to dental treatment. So overall, I hope this kind of makes the case of that antibiotics do not work for dental pain. Dental pain is caused by inflammation, and for inflammation and for dental pain, the best thing to prescribe is NSAIDs or non-steroidal anti-inflammatory drugs, mainly ibuprofen. So that was like the end of the guidelines, and as I've mentioned, these guidelines are relatively new. There isn't much literature on evaluating their like how they've impacted dental care or dental prescribing. This Dr. Durkin mentioned this study in his talk, so I'm going to talk about it also quickly. So I think it's the only available study looking at concordance of antibiotic prescribing with the ADA guidelines for acute oral infections. And this study used data from the VA. And as Dr. Durkin mentioned, the VA is just like an ideal setting to evaluate this because in the VA, they actually use diagnosis codes in addition to treatment codes, as opposed to the rest of like most dental claims data that only show you, that only include treatment codes or CTT codes. So we can only know what was done, but we don't know why it was done. With the VA data, we actually can see why the patient came in and why they got the procedure that they had. And so they evaluated data from 2017. So kind of, this is before the guidelines, so we can think of it as baseline data. And they identified over 470,000 dental visits with acute oral infections. And again, so this is within VA dental clinics. So dental care is immediately available. That was the assumption that they made. And so in these cases, antibiotics are only recommended for cases as an adjunct to dental treatment in cases of pulp necrosis with acute apical abscess and systemic involvement. So within the visits that they had for cases of irreversible pulpitis, only about 12% of patients received an antibiotic. For cases that had also apical periodontitis, 17% received an antibiotic. And then for cases of acute apical abscess, about 28% received an antibiotic. So for the first two cases, they were able to say that most antibiotic prescribing was within guidelines. For the cases of acute apical abscess, they were not able to assess systemic involvement within the VA data. So we couldn't really say that if prescribing here was appropriate or not. And so although the antibiotic prescribing was within guidelines of for to when to prescribe an antibiotic, they did find that regarding antibiotic duration, so remember the guidelines recommend 3 to 7 days, they found that 42% to 49% of antibiotics went beyond 7 days, and so they were not within guidelines. So overall, the authors think that there are opportunities for the ADA guidelines to standardize and improve dental prescribing practices. Now, the last part, which is how can I help my patients with acute oral infections, and this is geared to non-dental providers. So again, the most important thing is source control referred to dental care. Regardless of whatever the cause of the dental pain is, referring to dental care and getting dental treatment is the real, the only true treatment for these patients. And we know, I know realistically, because of this fragmented healthcare system, it's difficult. There are many barriers for patients to go, receive dental care, but it could be helpful for providers to have resources for dental care or like dental clinics that are available within the area, or federal or FQHCs or federal qualified health centers that may be able to take patients regardless, of their insurance status. And I just like to mention this as like a tangent, I guess, but there are efforts between the American Dental Association and the American College of Emergency Physicians to create those pathways between ED and dental care. So they have some programs where dentists volunteer to take patients who come from certain EDs with dental pain, or there are some health systems that have a dentist on site that can perform some procedures, or there was a health system that included an urgent dental care clinic within their hospital. So for, ideas for thought for people who would like to, who can actually incorporate some kind of referral between, ED and dental care. So again, the patient is in your clinic, they're in pain. How can you help them? They can't get to the dentist immediately. Regardless of what the cause of the dental pain is, evidence strongly supports ibuprofen. And so it's basically ibuprofen 400 milligrams with or without acetaminophen of 1,000 milligrams for dental pain, because it's driven by inflammation again, and it happens in the periphery. NSAIDs are optimal. Opioids are not really indicated for dental pain unless NSAIDs, I guess, are contraindicated. And I know we still don't have the guidelines for acute dental pain management are still coming up, but that is like the main idea, that for dental pain, NSAIDs are really the most effective evidence-based measure. To help the patients temporarily, to at least go over the acute phase or to help them until they get into dental pain, a provider can perform anesthesia. So here I put a picture of an inferior alveolar nerve block, and here maxillary infiltration. So providing anesthesia can actually help patients just withstand that pain until they get into the dentist. And I know training varies over the country with healthcare providers and their ability to perform these procedures. But again, the American College of Emergency Physicians, or ACIP, their annual meeting includes workshops on how to perform dental anesthesia and other treating other oral health emergencies. That could be a good resource. For infection, so that's only when you have that abscess. The best thing I guess you could help the patient with is perform incision and drainage of an abscess. And in terms of antibiotics, we'll go back to the guidelines. So assuming that dental care is not immediately available, antibiotics are only recommended in cases where there's an acute apical abscess with or without systemic involvement. And their guidelines also recommend delayed prescribing in cases where there's pulp necrosis or a dead tooth, and then there's symptomatic apical periodontitis. So a patient would usually complain of pain on biting or pain on like when you tap the tooth. And the recommended, again, the first line treatment recommendation is amoxicillin, 500 milligrams 3 times a day for 3 to 7 days. Again, remember, referring to dental treatment is the most important thing. Follow up with the patient and then tell the patient to discontinue antibiotics 24 hours after their symptoms resolve. And within these guidelines in general, patient communication is really important. It's important to tell the patient when they need antibiotics, when they don't need antibiotics, how they take the antibiotics when they are recommended, and then how to look for signs of adverse events from the antibiotics, or how to tell that the antibiotic is not working, and when to call the patient, their provider. And also it'd be helpful for the patient to learn how to dispose their antibiotics or not share them with other people. And then final slide is available resources for providers. These chairside guidelines on antibiotic use for dental pain and intraoral swelling have been mentioned earlier in this talk, and I think it's really helpful. This like flow chart of when to prescribe antibiotics. I know in the current form it's geared towards dentists, but I know that they're updating it to become more like non-dental provider friendly. This is a website called Smiles for Life Oral Health Curriculum, and it includes a lot of oral health modules for non-dental providers. It's online, it's free, and they have a module on acute dental problems that is, I think, a great resource. Finally, I want to mention the Dental Box. I don't work for them, I'm not advertising for them, but it's this box came out from the University of Pittsburgh and the University of Pittsburgh Medical Center. There's an ED provider, Dr. Kempenko, who was within a family of dentists. He was the only ED provider, and he realized that they don't have enough training, ED providers, to help patients with dental pain. So he learned some techniques from his dentist father, and then he made this dental box that has a lot of materials that are helpful for non-dental providers in the ED, such as like dental anesthesia, temporary fillings, and they have also some stuff for dental trauma. So that's like also a nice resource to have. I know some EDs already have them, but not everyone knows how to use the stuff inside it. So that's also an available resource. And today there have been so many amazing resources shared that I personally learned about, and I think they were shared also. So that's the end of my talk. Thank you so much for sticking around for the last session. And yeah, happy to answer any questions.
Well, that was amazing, Dr. Khouja. Wow, what very helpful, actionable information, and really, really timely. So I want to thank you for that excellent presentation. We'll go ahead and open it up for questions or comments. You can put them in the chat to the right of the screen under Q&A. Yeah, we had 15. I know we had more than 15 people on the session, so people are probably starting to wind down their day. It's possible, but let's go ahead and if there are any questions or comments, please put them in the Q&A box.
Yeah, I know it was a lot of information to cover.
It was good. I mean, you had a really good storyline to your presentation.
Thank you.
Say hi to Dr. Suda for me. When she was over in Illinois, we worked on the same exact project, and then also to inform some of the Illinois providers on what they can do around proper or appropriate prescribing.
Yeah, that's amazing. I mean, like, I honestly wasn't into antibiotics stewardship until I worked with Katie. And then I was like, wow, this is a really important thing. I've never, like, I was concentrated on opioids, but like, that's the other thing that Katie does. But I thought antibiotics is also like really timely with all these problems in the world with antibiotics.
Yeah, and your information around pain management through antibiotics was really interesting, because that's what we were taught in dental school too, is that, some of the pain is as a result of inflammation, pressure-induced pain due to inflammation. So if you're treating the inflammation either through incision and drainage and or antibiotics, the pain is going to get better too, or the perception of pain is going to get better too. But clearly the studies that you showed, there's no connection between those two. That was interesting.
Yeah, I mean, like that's again with the in my qualitative work with ED providers, it constantly came up. They're like, why not an antibiotic? To them it makes sense, and I feel like even with dentistry, we still are not completely sure about what the role of antibiotics are in dental pain. And I feel that's where we can do a lot of work to prescribe better. And I mean, for me, I feel like if people had adequate access to dental care, especially preventive dental care, like that would be great, right? We wouldn't have a lot of these conversations, but especially within the ED. But yeah, like when we have to help the patient, and we can get dental treatment, then we want to do the right thing for the patient, right?
Right. Yeah, and the fact that dental care is fragmented, we really do need to work with the rest of our medical colleagues so that they could help us be more preventive focused and that. Right. Yeah. So excellent. So I guess if there are no questions, let's see. I don't see any. And well, we have you until 4:45. Is there anything else? Yeah. So another thing that I want to do in Illinois is to really look at our opioid data, the opioid prescribing data, which I think you all are starting to do more closely for your own state, or are you looking at it nationally?
Within the Optum data, I'm looking at it nationally. We also looked at it with Katie's data. She has the Acute LRX data. Again, we looked at it nationally, and it's very promising with dental providers. We see a trend of decreased opioid prescribing. But then there's a lot of variation, right, between states and within provider type. So we see that general dentists have dropped their opioid prescribing more than oral surgeons, for example. But then the problem again with claims data is that we don't have those diagnosis codes. Right. So we can't tell if oral surgeons are doing all these like really severe, complicated procedures, and like an opioid may be warranted, versus general dentists are just doing fillings or something like that, and so they don't need to prescribe as much. But I feel like we're heading towards the right direction, but we still need more like focused efforts for those people who are kind of resistant, I guess, or still prescribing, or
Right. I mean, I recently had an experience where my daughter had to have her third molars removed, and I mean, in the pre-op, the surgeon said, okay, we're going to be doing this, we're going to be doing that, and then we're going to be doing this to manage pain. And I had to push back, and I said, no, what we need to do manage pain is to limit the invasiveness and trauma, number one. We should probably also pre-op with ibuprofen type product. And so, I mean, I don't know if the evidence is there with that, but we went ahead and did that.
Yeah, preemptive analgesia, giving the patient like ibuprofen.
The day before. Yeah, we started the day before, the night before, the morning of, and then, so that we did those two. And then, they still wanted to give her an opioid medication. And I'm like, she's 19. We know what you did. I don't think we need it. And, so we had to be like pretty proactive on not taking it.
Yeah, and I feel like that's especially, I mean, like anecdotally talking to to dentists and oral surgeons, I feel like oral surgeons still have that belief of, well, what if the patient is in pain, right? And And I guess some of them don't want to be bothered right after hours, or like patient getting, in pain over the weekend, stuff like that. But I feel like we need to like believe the evidence. And like I'm from Saudi Arabia, and it's not just inside. So outside of North America, I should say, people don't prescribe opioids for dental pain, period. Like whatever the procedure is, it's NSAIDs.
The other thing I think that, I didn't recognize was that, you can do all those things like limit the trauma, pre-op pain, limit the surgical site, etc. But after the event, you need to be able to support the patient as a family member, like, this is what we need to do. Set your clock to take this medicine at 6 o'clock, this medicine, you know what I mean? Because we're cycling the ibuprofen and the Tylenol, and you need to be on it. So you have to have a supportive environment too. So that was the other thing that I didn't recognize, and that needs to extend for like 3 to 5 days post-op.
That's a very good point. Like inpatient communication is that, like telling them of the timing, having someone to help them. And also I think like all those like non-pharmacological ways of managing pain, like, resting basically, and like using ice, or, all those things. Don't chew a lot, don't eat spicy, all that kind of stuff actually really helps. And also like patient expectation that there will be some discomfort, there will be some pain, but it's short-lived, right? Like you can, it's like 3 days hopefully, and then it will be almost over, like you can live with it. There's no such thing as 100% pain-free.
Yes. Exactly. Yeah, exactly. So you have to have this whole package when you say, this is not the best medication for you, but you can do this, you can control this. Yes, it's not going to be pain-free. Nothing really is. I mean, you're incising, removing bone, etc. So.
And knocking you off isn't gonna like really help you.
Exactly. That was the other thing they wanted to do. Give her general anesthesia. I'm like, wait, this is just this is straightforward. The other thing I wanted to do is take 2 out at a time, but they convinced us to do all 4, and then they were going to do general. And I'm like, no general, we can do this. We've seen it. I'm a dentist myself, I know how, and you're an expert, so anyway, I want to just thank you so much for a wonderful presentation again. I know that we're at time. I don't see any questions. Dr. Khouja, I want to again thank you and hope that we have some opportunity to interact again, because you had such terrific information for us.
Thank you so much. Thank you for everyone who hung up to stuck with us till the end.
Yes. All right. Okay, great. We'll see you all at the wrap-up and evaluation session, which should be popping up pretty soon. Okay.
Thank you.
Okay, bye-bye.